One, two, three, start.
Good morning.
We are
From Group 3A-1. I'm Nushinda.
I'm Go.
I'm Ferdina. I'm Shazwin. Today we're going to present on hospital-acquired pneumonia. The reasons why we have chosen this case were first, as this was our first time to handle and provide care for patient on ventilator. Next is to take the initiative to learn on relating and understand the complex pathological relationship of one disease to another. What makes this case more challenging is when we found out that the patient also faced many complications due to his primary diagnosis, such as complicated parapneumonic effusion, respiratory failure type 1, and acute respiratory distress syndrome, which is known as ARDS. This case caught our attention and interest when the patient was found suffering tension pneumothorax, likely due to the ventilator. This problem raised our curiosity on how does a ventilator, which was supposed to give this patient the breathing support he needed, could cause further problem to the patient.
Our subject is Mr. M, a 56 years old single gentleman. Currently, he lives with his young brother at number 70 Kampung Putih, Sematan. He works as odd jobs. The case is referred from Lundu Hospital for CAP with bronchospasm. Then the case is transferred to SGH for worsening respiratory distress. And he admitted to May Medical Ward on 1st October 2018 at 12:15 p.m. On 1st October 2018, he came to ETD accompanied by his brother. His condition was alert, conscious, and able to speak with full sentence with GCS of 15/15. During that time, he was complaining fever with chills and rigor, but no runny nose and sore throat. The fever usually lasts for more than 3 days. He has underlying with bilateral eye blindness since birth, okay, with no perception to light for both eyes. He has no known other medical illness, and he is newly diagnosed with hospital-acquired pneumonia with bronchospasm, acute kidney injury on chronic kidney disease, and pneumothorax upon his admission to May Medical Ward on 1st October 2018. An examination has been conducted in order to diagnose his medical problems. Condition based on Gordon's functional health pattern to gain more information regarding his condition and to assess for his body function. We also have done some physical examinations on Mr. M to further check his body function and status. The patient has undergone several diagnostic tests which include arterial blood gases. ABG is performed to see how well lungs are functioning and to determine the effectiveness of the respiratory therapies. Next, the result for urine FME. There were protein present in the urine of 2 positive is 0.75 gram per liter, which indicated proteinuria. And for the erythrocyte, it showed positive result which may indicative of hematuria. For the ETT CNS, it was taken on 14 October 2018, and the result shown that there is presence of Enterobacter ESBL positive, which indicated that this patient has been infected by Enterobacter. Next, for sputum CNS, it was taken on 1st October during his admission, and the result is negative. But on 14 October, the sputum CNS was collected through ETT, and the result is there is presence of MRO Echinotobacter, and based on the result, it showed that this patient's respiratory tract has been infected. Next, USG abdomen is performed to produce pictures of structures within the upper abdomen, including organs such as kidney, gallbladder, and liver. For this patient, the USG abdomen is planned to rule out obstructive uropathy and was done on 10 May 2018 to evaluate the kidney. The results show that he had bilateral renal parenchymal disease with right kidney of 8.2 cm and left kidney of 8.3 cm. There was no obstructive uropathy and no presence of stone or hydronephrosis. Next, chest X-ray for this patient is done on 1st October 2018 and is showing dense homogeneous opacity in upper lobe of his right lung and also right lobar pneumonia with bronchospasms. For the blood film for malaria parasite, it is the blood film for malaria parasite for malaria diagnosis, which is done and repeated for 3 times from 29 September 2018 to 1st October 2018 to detect the presence of parasite. And the result is negative and no parasite was found. For the mycoplasma serology, it is done to diagnose a systemic infection that is thought to be due to mycoplasma. This test is done on 5th October 2018 and the result is negative, which there are no antibodies to pneumonia were detected.
Of the organisms enter the lungs after microaspiration of bacteria which colonize the patient's own oropharynx and upper airways in critically ill patients. Once the bacteria invades the alveoli after the host defense mechanisms is overwhelmed by the microorganisms' virulence, the bacteria will release endotoxin and initiating inflammation process which leads to proliferation of neutrophils. The bacterial production of endotoxin will induce fever to the patient. During the inflammatory process, the neutrophil will release cellular mediators such as cytokines which will increase the pulmonary capillary membrane permeability, thus causing the intravascular fluid to enter the interstitial space and eventually into the alveolar space. At the same time, the muscle that lines the bronchi swells due to the inflammation, thus resulting in bronchospasm, and the patient will have difficulty in breathing. This process will also overwhelm the macrophage, thus resulting in accumulation of fibrinous exudate and bacteria that fills the infected and adjacent alveolar spaces, making them stick together as well as airless. At this point, the patient will experience symptoms like productive cough. The inflammatory process and increase in membrane permeability will eventually cause extravasation and accumulation of bacterial fluid in the pleural space, which then leads to complicated pneumonic effusion. The accumulation of fluid in the alveolar space will make the oxygen to have difficulty to pass through the membrane while maintaining normal elimination of carbon dioxide, as carbon dioxide diffuses easily in fluid compared to oxygen. This condition is known as respiratory failure type 1. Then, the body will also be in distress since the cells have increased demand for oxygen, thus leading to acute respiratory distress syndrome, which is known as ARDS. Often patients with CKD are at high risk of developing AKI, a condition known as acute kidney injury or chronic kidney disease. However, recent studies stated that the exact pathological relationship between CKD and AKI is not completely understood. Nonetheless, Su and Su 2016 stated that a possible reason for this problem may be that patients with CKD experience more acute medical illnesses requiring hospitalizations and procedures that increase the risk of exposure to nephrotoxic insults. Intubated patients are at high risk of developing barotrauma since the high positive air pressure within the lungs does not leak out. Therefore, there is an extra alveolar air due to the extreme increase in air pressure which causes overdistension and rupture of alveolar walls. The air may escape into the pleural space from the alveoli or interstitium which then accumulate and become trapped. This trapped air in the pleural space increases pleural pressure and collapses the lungs, thus leading in tension pneumothorax where the lung can receive air upon inspiration but unable to expel air during expiration. Due to this build-up of pressure within the lung cavity, the lung will be unable to serve its function normally to obtain adequate oxygenation and insufficiently expel carbon dioxide. Hence, the carbon dioxide will accumulate in the blood due to inadequate ventilation, and this condition is known as respiratory failure type 2.
To manage the CAP patient, we need to assess the severity of the CAP. Some tools can be used like PSI PRRT, CURB65, modified IDSA and TS criteria. These can be used to determine whether the patient can be treated as outpatient or inpatient. Smart Cord is used to predict the patient that need intensive respiratory and vasopressor support and the need for ICU admission. Next is the antibiotic therapy. The initial antibiotic treatment has to be empirical and should start promptly with appropriate selection. This is because to have a better outcome, like shorter length of staying in hospital. After that, the sample for culture and sensitivity need to be taken and sent to the lab. This is because causative organism can be identified and the change of the antibiotic regime as well. Next is the mechanical ventilation. Some patients need the mechanical ventilator support to protect the airway, as the patient while having the respiratory distress like tachypnea. On 28 October 2018, the patient is intubated under sedation. The SIMV-VC mode is used with the FiO2 0.8, tidal volume for 120 mL, ventilator rate 16 breath per minute, pressure support, and the PEEP 16 and 10 cm H2O respectively. After patient being intubated, the ABG and CXR will be done to make sure the placement of the mechanical ventilator, the ETT, need to be assessed. Other supportive treatment is done like regular suctioning, collaborate with physiotherapy, chest physiotherapy technique like percussion and vibration will aid in secretion removing, and also limb physiotherapy will help patient to maintain the muscle tone and strength as patient being bedridden. Bromhexine 8 mg is prescribed and administered to loosen the mucus secretion. Management for pneumothorax. On 16 October 2018, the patient had complicated barotrauma and tension pneumothorax, most likely due to high ventilator setting. First, the management is the needle thoracostomy with a large bore needle inserted, and then a chest tube is inserted and placed into fourth intercostal space and attached to underwater seal drainage system. However, this complicated barotrauma can be avoided by limiting the tidal volume and plug pressure to less than 30 to 50 cm H2O. After that, on 29 October 2018, the chest X-ray revealed that the patient having complicated parapulmonic effusion. So another chest tube is inserted below one rib, previous chest tube placement under aseptic technique. To manage the chest tube drainage system, we need to monitor closely by observing any bubbling and fluctuating. Look for and document the amount and color of drainage. Keep drainage system below the patient heart level and prevent kinking of the tubing. And assess any sign of symptom that patient having respiratory distress. Ensure the dressing on the incision site is intact and change when soiled. Management for uncontrolled hypertension. First, we need to monitor the blood pressure hourly and inform if high. That is, the systolic pressure more than 150 mmHg for the patient. Reduce sodium and fat intake although the patient is on NG feeding. Some pharmacological intervention like tablet prazosin 3 mg TDS, tablet felotipine 10 mg PD, and the IV furosemide 80 mg TDS is given and administered to the patient to control the hypertension. For the acute kidney injury, chronic kidney disease, and anemia, the management is that patient having the fluid restriction 700 cc per day on Nova Source 100 cc given every 3 hourly through NG tube. Hemodialysis when necessary, that is, when patient having poor urine output, positive balance of intake and output, and increased blood urea and creatinine level. For the anemia, if the patient hemoglobin level is too low, the blood transfusion, the PEG cell, is needed during hemodialysis.
Nursing care plan. The first assessment was done on 29th of October of 2018 at 9:30 a.m. The first nursing diagnosis is ineffective airway clearance related to presence of artificial airway, which is endotracheal tube, and inability to cough up secretions from the respiratory tract, as evidenced by SpO2 of 85% to 89% under SIMV mode with oxygen concentration of 0.7, ABG result of PO2 of 57.3, and respiration rate of 29 breaths per minute, and patient also look restless. Nursing goal for this nursing diagnosis is patient will be able to have normal respiratory status, which is SpO2 increase within accepted range, which is more than 92%. ABG result will show PO2 increase within normal range, which is 80 to 100 mmHg. Respiration rate will be reduced from 29 breaths per minute to 16 to 20 breaths per minute, and patient will be able to comfort himself within 15 minutes. Nursing interventions. First, assess vital signs such as respiration rate, oxygen saturation, pulse rate, blood pressure, and temperature to obtain baseline data for comparison. Second, position the patient to semi-fowler's or high fowler's position to enhance lungs expansion. Third, monitor oxygen saturation level of the patient hourly by using pulse oximetry to ensure oxygen saturation within accepted range. Fourth, perform suctioning via endotracheal tube and oral to remove the secretions and promote patent airway to the patients. Fifth, perform mechanical ventilation by using bag valve mask to the patient to provide effective lung expansion and promote gases exchange. Sixth, discuss with the doctor to increase oxygen concentration of ventilator to make sure patient receive adequate oxygen. And lastly, administer medication as prescribed to the patient accordingly, which is tablet bromhexines 8 mg TDS to loosen the secretion over airway tract. Nursing outcome. Patient's SpO2 increased from 86% to 89% to the 97% under SIMV mode with oxygen concentration of 1.0. Respiration rate reduced from 29 breaths per minute to 21 breaths per minute, and patient look calm and comfort. ABG result of PO2 increased from 57.3 to 67.8 mmHg, and it gradually increased over time to 106.5 mmHg. The second assessment was done on the same day at 9:45 a.m. The second nursing diagnosis is impact gases exchange related to accumulation of fluid in air sac of the lungs secondary to pneumonia, as evidenced by oxygen saturation level of the patient is 86% to 89% under SIMV mode with oxygen concentration of 0.7. Nursing goal is patients will be able to increase SpO2 level from 86 to 89% within accepted range, which is more than 92% within 15 minutes. Nursing intervention. First, assess patient's oxygen saturations by using pulse oximetry by noting the rate, pattern, and range of the reading to obtain baseline data for evaluating effectiveness of nursing plan for the patients. Second, auscultate the lungs to assess breath sound bilaterally for comparison to note any abnormal breath sounds that may indicate fluid or mucus accumulation over the air sacs. Third, monitor oxygen saturation level of the patient hourly to ensure oxygen saturation level is within accepted range for the patient and alert any changes for immediate nursing interventions. Fourth, position patient in semi or high fowler's positions to promote lung expansion and improve gases exchange. Fifth, discuss with the doctor to increase oxygen concentration of ventilator to ensure enough oxygen uptake by the patients and to improve effectiveness of gases nursing outcome. Patients able to increase SpO2 from 86% to 89% to 97% under SIMV mode with oxygen concentration of 1.0 within 15 minutes. The third assessment also done on the same day, which is at 10:15 a.m. The nursing diagnosis is impaired physical mobility related to associated medical diagnosis, which is bilateral blindness since birth. Patients on ventilator support and sedation also given to the patients, as evidenced by patient is on SIMV ventilator. GCS of 3+T/15 and he also cannot perform his activity daily living by himself. Nursing goal. Patient will be able to meet his daily needs and feel comfortable within hospitalization. Nursing interventions. First, assess the degree of immobility of the patients to obtain baseline data for comparison. Second, assist patient in his independent ADL to ensure patients meet his needs in daily living. Third, communicate with the patients when do any procedure to avoid anxiety and to gain cooperation from the patients. Fourth, assist patients in active and passive exercise to improve blood circulation to the muscle, tissues and bone and to prevent complications. Fifth, advise family members to always be near with the patients and help as needed to reduce and eliminate any complications such as fall from the bed. Nursing outcome. Patients able to meet his daily needs with help from the nurses and relatives and felt comfortable within hospitalization. The fourth assessment also was done on the same day at 10:20 a.m. Nursing diagnosis is altered skin integrity related to altered circulation over sacral area as patient is bedridden as evidenced by skin breakdown over sacral area with size of 3 × 5 cm with stage 2. Nursing goal. Patient's wound over sacral area will be gradually healed without any complications within hospitalizations. Nursing interventions. First, assess the degree of pressure ulcer to determine effective nursing care for the patients. 4. Avoid position the patient on side of skin impairment to reduce friction and pressure over affected area and enhance wound healing process. 5th, maintain aseptic techniques for daily dressing and wound care for the patient to prevent cross-contamination during clean the wound. 6th, discard salt dressing and change as soon as possible to prevent the growth of microorganisms over the wound. 7. Discuss with dietitian to increase protein intake to enhance wound healing. Nursing outcome. Patient's wound appear clean, whitish tissue with minimal serous discharge and seems free from any complications within hospitalizations. Discussions. From this case, we have come out with two questions. First, why the SpO2 stay low, which is less than 90% even though the nurses have done suctioning and the patients on ventilation and also given manual ventilations. Second, why did patients did not tolerate with Nova Sosranum?
What we have learned from this case is that the management of critically ill patients may cause the patients to develop other complications.
But in fact, this management approach to save the life of the patient, even though it may cause some adverse effect to health conditions.
So it is our responsibility as a healthcare professionals to deliver an efficient management